Good day to those tuning in. My name is Lieutenant Jeff Caudill. I'm a Radiation Health Officer with the Medical Service Corps. Today we're going to go over fluoroscopy training for those operating fluoroscopy machines for diagnostic imaging procedures. The first thing that comes to mind, why exactly am I doing this training? Well, the National Council on Radiation Protection and Measurement has a report 105 that states all radiation workers need to be aware of all rules and practices in the work situation that attribute to effective radiation exposure management. The American Association of Physicists in Medicine have a 1998 report, number 58, that states an effective radiation protection program requires employees to receive annual education. The 2007 recommendations of the International Commission of Radiological Protection states that medical practitioners need to have specific training in radiologic protection that's specific to each modality of ionizing radiation. The Defense Health Agency requires both radiation workers and non-radiation workers to go over the ALAR concept, which includes time, distance, and shielding. And finally, the Joint Commission, our accrediting body for all Department of Defense healthcare facilities, requires staff to participate in and document ongoing education and training. So in conclusion, all licensed physicians and X-ray technologists should be permitted to operate fluoroscopy, and you need to have your required initial and annual training. Today's training is divided into 4 topics: a fluoroscopy and basic radiation overview, basic radiation biology, patient radiation exposure, and occupational radiation protection. Fluoroscopy is the continuous acquisition of a sequence of X-ray images over time, essentially real-time X-ray of the patient. Modern general-purpose X-ray uses pulsed X-ray beam in conjunction with a digital image acquisition. Let's take a look at the major components of a fluoroscope. A fluoroscopy system consists of a few standard components: an X-ray tube, a collimator, an anti-scatter grid, and finally an image intensifier or digital detector depending on the age of your system. Let's focus on the X-ray tube head. It consists of an anode and a cathode, which is also called the target, and electrons and X-rays that are produced as a result of the interaction between the anode and cathode. When high-energy electrons are fired from the anode, they reach the cathode to interact with the material of the target, which is typically tungsten. When the electrons interact to create X-rays, only about 1% of the interactions produce X-rays. The remaining 99% merely generates heat. Now, of that 1% X-rays, 90% is Bremsstrahlung radiation. The other 10% are characteristic X-rays. When an electron comes into close proximity of a nucleus, the attraction between the negative charge of the electron and the positive charge from the protons in the nucleus causes the electron to effectively break. Bremsstrahlung is German for breaking, so we have Bremsstrahlung radiation, which is 90%. Now, here you can see that we have an unfiltered Bremsstrahlung spectrum and a filtered Bremsstrahlung spectrum. Part of the 21 CFR 1020 criteria says that there needs to be some inherent filtration to reduce the number of low-energy X-rays coming from the X-ray tube, which is why you see a shift in the spectrum. Next, we have characteristic X-rays, which make up 10% of the X-rays produced. One of those high-energy electrons is coming at the nucleus of the tungsten material in the target, and the negative charge of the electron repels one of the orbital electrons from the tungsten atom. It causes one of those orbital electrons to get discharged from its orbit, freeing or making a vacant hole in the orbit around the nucleus. This creates a need to fill that vacant hole, and when it does, the difference in the binding energies releases some of that energy in the form of a gamma, which is called a characteristic X-ray. The final picture we see on the screen is the combination of both our Bremsstrahlung spectrum and our characteristic X-ray radiation, which is what we have coming from our X-ray tube head used to create our diagnostic images. KERMA is an acronym that stands for Kinetic Energy Released in Matter. It's the kinetic energy transferred to charged particles by indirectly ionizing radiation per unit mass. In step 1, the energy carried by X-rays is transformed into kinetic energy of charged particles primarily by Compton scattering. In this picture, you can see an incident photon enter near an orbital electron where it interacts and causes the energy to be deposited, freeing that Compton electron from its orbit. In Compton scattering, a scattered photon with a decreased energy continues on to interact further with other matter. In step 2, electrons deposit their energy in air and tissue by ionization. In ionization, an incident ionizing electron will come into vicinity of an orbital electron, and the repulsive force will cause it to be free from its orbit around the nucleus, leaving a vacant shell and the atom with a positive charge. Absorbed dose is also defined as the amount of energy in joules deposited per unit mass, with the unit being the gray. When kerma releases its kinetic energy into human tissue, the amount of energy absorbed by the patient is the radiation dose. The amount of energy deposited retains the same units, only the medium of energy deposited has changed. Dose differs from kerma in that it only includes the energy deposited in tissue. The energy that escapes is captured as the variable G, which for diagnostic X-rays, that value is very small, less than 0.1%. So, for diagnostic X-rays, we can assume that dose is the same as kerma. They're basically the same value. The Joint Commission's chapter on provision of care, treatment, and services requires hospitals to document the cumulative air kerma or kerma area product in a retrievable format. This is accomplished by the radiologist documenting the value in the picture archiving communication system along with the imaging study when it's captured. Not all types of ionizing radiation cause the same biological damage per unit of absorbed dose. To modify the dose to reflect the relative effectiveness of the type of radiation, a radiation weighting factor is used. The product of the absorbed dose and the radiation weighting factor creates what's called an equivalent dose. The SI unit for equivalent dose is joule per kilogram with the special name of sievert. Radiations used in diagnostic imaging, or X-rays, include the energetic electrons produced as a result of the interaction. So they have a radiation weighting factor of 1. So said another way, for the purpose of diagnostic X-rays, 1 gray equals 1 sievert. Therefore, with the radiation weighting factor of 1 sievert per gray times 1 gray, you get 1 sievert. Biological tissues vary in sensitivity to the effects of ionizing radiation. The ICRP established tissue weighting factors to assign each particular organ or tissue the proportion of detriment from stochastic effects like cancer or hereditary effects. Then you can compare that to a whole body exposure. So as you can see on the screen, we have some of the various tissue weighting factors straight out of ICRP 103 from 2007. The effective dose is the sum of each equivalent dose to each organ or tissue, corresponding with the weighting factor. Effective dose can be used as a comparison of the risk from diagnostic imaging studies or occupational work with ionizing radiation to the risk from other radiation sources, such as cosmic radiation or radon in rocks and soil. The study of the action of ionizing radiation on healthy and or diseased tissue is the scientific discipline known as radiation biology. Radiation interactions that produce biologic changes are classified as either direct or indirect. For the purpose of this training, we're only discussing X-rays, so we're only going to discuss indirect interactions. Those refer to the effects that are a result of the radiation interactions within the body that create reactive chemical species, which then go on to interact with the DNA in the cell. Because water makes up 70% of the human body, the majority of radiation-induced damage from medical X-rays is caused by radiation interactions with these water molecules. The majority of X-ray interactions lead to the production of hydrogen peroxide and the hydroperoxyl radical, which are highly toxic and damages the cell's DNA. There are many ways that the cell can have damage, as you can see on the screen, but most importantly, there's single-strand breaks, double-strand breaks, or complex damage. DNA damage is a relatively common event in the life of a cell, but the mutation rate is extremely low due to the effectiveness of the cell's DNA repair mechanisms. Radiosensitivity is defined as the relative susceptibility of cells, tissues, organs, or organisms to harmful effects of ionizing radiation. In 1906, two French scientists Jean Bergoni and Louis Tribundeau performed a series of experiments that determined the fundamental characteristics of cells that affect their relative radiosensitivities. The law of Bergoni and Tribundeau states that the radiosensitivity is greatest for those cells that have a high mitotic or division rate, have a long dividing future, and are undifferentiated, or the purpose of the cell is undefined. So we can see that spermatogonia or lymphocytes, white blood cells, are more sensitive, whereas very defined cells, such as those in bone or the central nervous system, are least sensitive, or they are very radioresistant. If a radiation exposure is very high, the number one biologic effect is cell killing. This will present over time as the exposed tissue degenerates, such as the reddening of the skin with erythema. Deterministic effects have a threshold, which means that below that threshold there will be no effect to the tissue. But as you increase the exposure above that threshold, it will increase linearly proportional to the amount of absorbed dose. Take a look at this picture from the World Health Organization's publication on skin injuries from fluoroscopic procedures. The major concern in fluoroscopy is the possibility of acute radiation damage, which will manifest as skin injury. So pay attention to this graph. Erythema has a typical threshold absorbed dose of 6 gray. And finally, an organ's response to radiation will depend on many factors. The total dose, the dose rate, the fractionation scheme, which is how the total radiation is divided into separate sessions, the volume of irradiated tissue, and the radiation sensitivity of that tissue, similar to the tissue weighting factor we just discussed. Let's take a look at an extreme example of organ damage by looking at a case of skin injury. Remember, when we talk about this case, we said that the typical threshold for erythema was 6 gray. We have a 49-year-old man with a history of liver cirrhosis and gastrointestinal bleeding. He underwent 3 TIPS placements or attempts within a 1-week period. At 6 months, you can see a secondary ulceration with D and hyperpigmentation. At 7.5 months, you see small blisters develop. At 10 months, you see that the wound has gotten bigger in size and depth. At 22 months, the patient is still having complications from the procedure where there's pain in the non-healing ulcer. And at 23 months, the patient finally received a skin graft, but the disfigurement from this procedure was permanent. Through additional research, I was able to say that the TIPS procedure will typically have a dose range of 20 to 35 milligray, requiring anywhere between 15 and 93 minutes of fluoroscopy beam on time. But looking at the pictures, we know that the patient didn't have just erythema. He had epilation, blistering, moist desquamation. So the practices that the fluoroscope operator employed were not optimal, and it produced way more than the 20 to 35 milligray that I just mentioned. Please don't let this extreme example scare you. Take a look at the table on the screen where we display a mean entrance skin dose for some common diagnostic fluoroscopy values. A barium swallow, for example, has a mean entrance skin dose of 44 milligray. More intense fluoroscopy procedures that involve interventional radiology will inherently require more beam on time than diagnostic radiology. On the table on the screen, a cerebral embolization, the highest value on the table, has a mean entrance skin dose of 340 milligray. But out of all these values, none of them come close to the 6 gray or 6,000 milligray required to cause an onset of erythema. Let's take a look at our accrediting body to determine what can be implemented to drive home some safety measures to prevent these from occurring. The Joint Commission's chapter on the provision of care, treatment, and services requires the organization to identify radiation exposure and skin dose threshold levels that, if exceeded, trigger further review and/or patient evaluation. Additionally, the Joint Commission's Performance Improvement chapter requires hospitals to review and analyze instances where the radiation exposure and skin dose threshold levels identified by the organization have been exceeded. In 2006, the Joint Commission added radiation overdose as a reviewable sentinel event under its sentinel event policies. specifically of prolonged fluoroscopy with a cumulative dose greater than 1500 rad or 15 gray in our case to a single field. Each facility is different, but at my facility, we have established a trigger level of 150 rad or 1.5 gray cumulative dose to a single field. This trigger necessitates notice and involvement of the radiation safety officer for patient safety considerations. So you should be asking, has your facility instituted any policies to trigger possible patient safety risks? Stochastic effects are regarded as the principal health risk from low-dose radiation, including exposures of patient and staff to radiation from diagnostic imaging procedures. Stochastic risk, more briefly put, is cancer risk. So, according to the American Cancer Society, approximately 40% of the population will develop cancer, and 1 in 5 people will die from cancer during their lifetime. From 1980 to 2006, the average exposure to medical ionizing radiation has increased from 0.5 millisieverts to 3 millisieverts per year. With the increase in patient radiation exposure, it's important to be able to relay to patients the safety of diagnostic imaging involving ionizing radiation. According to the NCRP's Report 160, Americans receive a radiation dose of about 6.2 millisieverts per year. 3.1 millisieverts comes from natural background radiation, such as radon and cosmic radiation from the sun. An additional 3.1 millisieverts comes from man-made sources of radiation, including CT and fluoroscopy. Let's take a look at a risk comparison laid out by Fahey et al. In their 2011 article on minimizing and communicating radiation risk in pediatric nuclear medicine. There are 2,500 small circles on the screen. The red star in the bottom right corner represents the risk of cancer from a 4.2 millisievert exposure to ionizing radiation. In contrast, there are 550 dark blue circles that represent the number of the original 2,500 that will naturally die of cancer, which is approximately 20%. The younger the child, the more sensitive his or her body is. Remember, the body is still growing, therefore there are fewer cells that have differentiated in the body into specialized cells. Additionally, children have longer expected lifetime for the effects of radiation exposure to develop into cancer. Therefore, the cells have a longer mitotic lifespan. Families should receive information describing any diagnostic imaging study before the day of the examination. The physician who requests the examination or the hospital or the facility personnel can provide this information at the time of scheduling. Providing parents with simple brochures before the procedure is shown to improve parents' understanding. And on the screen, you can see an example from the Image Gently campaign of a GI barium swallow fluoroscopic examination. The decision to perform a radiologic procedure on a patient who may be pregnant is a medical decision and shall be made by a physician in consultation with the patient. If the procedure is to be performed, the physician must explain the risks to the patient and provide informed consent. So you explain the risks to the patient, answer any questions the patient has, and provide informed consent and obtain signature from the patient. Take the following precautions when you're doing the diagnostic exam. Shielding shall be used to shield the abdomen from radiation. Every attempt must be made to minimize direct exposure to the fetus. And of course, life-saving radiologic procedures always take precedence over pregnancy status. Next, we'll move on to talking about specific ways to reduce radiation exposure to our patients. This area of the training relies heavily on the Image Gently Alliance's pause and pulse concepts. While designed for children, they are fairly universal and can be applied to adults as well. Pause to properly plan and prepare. Activate dose-saving features of equipment. No exposures unless necessary. Depress last image hold. And pulse at the lowest possible rate. When pausing to properly plan and prepare for a study, look at the medical history. Review any medical or surgical history. Review any available prior imaging, which can help to identify unusual anatomy. Plan your techniques. Radiologists and technologists making a plan of how to image a patient can decrease fluoroscopy exposure time. And when working with children, be as flexible as possible. Think through the following questions. Will there be a potential need for immobilization equipment? How will the child react if the parent's not in the room with the child? The responsibility rests on the equipment operators to optimize radiation dose, such that the radiation should consist of and not exceed the amount needed to capture a diagnostic study. The radiation dose associated with fluoroscopic procedures is highly variable and depends on a few different factors. The number of images obtained, the amount of radiation used to generate each image, the length of the radiation exposure, and the mode of image acquisition, for example, pulse or continuous. There are some features that may be manufacturer specific. Timers, for example, can be set to terminate fluoroscopy when time exceeds specific lengths. This allows facilities to stay within locally established patient exposure benchmarks. Manufacturers may have their own patented proprietary software that serves to decrease patient radiation exposure based on anatomy. And most fluoroscopic equipment is equipped with normal dose and high dose rate modes, but some equipment may offer even lower dose rate modes that can be used on smaller adults and children. In this picture, you may be familiar with the terms low dose fluoro and high dose fluoro, but this specific manufacturer has a 1/2 dose and 1/4 dose feature, so you can lower the radiation exposure proportionally. Radiation exposure to the patient should not occur unless it's clinically necessary. There are multiple things we can do to reduce unnecessary exposures. Get optimal imaging the first time through adequate training and departmental procedures. For example, PQS, Personnel Qualification Standards. Double check your patient positioning. Verify shielding positioning and usage. Consult with radiologists on suitability of imaging requested if unsure. Visit the Image Wisely and Image Gently websites for provider education. And finally, reference the ACR appropriateness criteria. With that, let's take a look at the ACR appropriateness criteria, which is a list of modalities by order of peer-reviewed appropriateness to diagnose a clinical condition. To start, the American College of Radiology created a relative radiation level indication to relay ranges of effective doses from diagnostic imaging procedures. Recall from our radiobiology discussion that pediatric patients are at inherently higher risk from exposure, so the relative radiation level dose estimate ranges for pediatric examinations are lower than compared with the adults. Reviewing the ACR appropriateness criteria for females with infertility and suspicion of tubal occlusion on initial imaging, an HSG is considered usually appropriate, which is attributed to the success of the HSG by increasing pregnancy rates up to 38%. Last image hold is the display of the last fluoroscopic image on the display monitor when the fluoroscopy pedal or hand switch is released. By use of this function, the radiologist can spend as much time as necessary studying the anatomy and other findings without incurring additional radiation dose to the patient. Always use last image hold when possible to study the anatomy. Continuous fluoroscopy has been used for decades, and it's seen in row A. Row B, we increase the current and pulse at 30 frames per second. The current's higher, so the radiation rate stays the same. In row C, the overall radiation exposure is reduced by reducing to 15 frames per second. Take a look at the diagram on the screen to see the dose rate reduction by shifting from continuous to various frame rates of pulsed fluoroscopy. You can review the results of various frame rates and their commensurate dose savings with your radiation safety officer. Take a look at the results on the screen from a diagnostic equipment survey I performed on one of our fluoroscopy units. You can see how the air Kerma rate increases as pulse rate is increased. When X-rays travel through the body, they interact and produce secondary scattered radiation. The scattered radiation from the patient contributes to staph exposure during fluoroscopy. It's also a source of electronic noise, degrading the signal-to-noise ratio. The anti-scatter grid on the screen stops scattered radiation as it is not traveling relatively parallel with the septa, the vertical separators in the grid. With the grid in place, the primary radiation reaches the detector, but the scattered radiation is prevented from reaching it. Studies have shown that, especially in pediatric cases, removal of the grid has resulted in a dose reduction of up to 1/3 to 1/2 with little or no degradation in contrast or image quality. With the two graphs on the screen, you can compare the relative radiation exposure rates with grid in and grid out. And you can see that with the grid out, you have a significant dose reduction to the patient. In the same paper these graphs were published, the 2011 paper by Hernandez-Schulman, it's demonstrated that by removing the anti-scatter grid, you can reduce radiation exposure to a 1-year-old by 87%. That is significant dose savings to the patient.
When imaging patients, you want to use the largest field of view possible. With image intensifier systems, this is accomplished by increasing the voltages applied to the electrodes, therefore increasing electron concentration. But for flat panel detectors, it's just a simple adjustment of the logic circuitry to increase the radiation exposure. Either way, when you increase your field of view, you are decreasing the magnification, and with decreased magnification, you get a decreased dose rate. The relationship of your field of views is seen by the equation on the screen. Your adjusted entrance skin exposure, or number 2, is equal to your entrance skin exposure number 1 times the square of the field of view 1 distance divided by the field of 2 distance. Let's say we have a 23 centimeter field of view and we have a 2 milligray entrance skin exposure. And then we magnify or decrease our field of view down to 11 centimeters. To move forward, what we do is take the 23 centimeters and 11 centimeters and substitute that. Then we substitute our 2 milligray times our new ratio of 4.4, and that leaves us with an adjusted or new entrance skin exposure of 8.8 milligray. Now, typically, your field of views can be adjusted right on the console, whether at the machine itself or a remote touch panel screen. Some machines have 2 field of views. This one on the screen has 4 field of views. But either way, just make sure that you're using the largest field of view possible for the diagnostic imaging at hand. Collimating to the area of interest is another key factor in reducing patient exposure. When you collimate, you're reducing the X-ray field down to the anatomy of interest that you're imaging. This decreases the volume of patient tissue exposed to radiation, and as a result, it improves your image quality because you have less scatter from the surrounding tissue. And as a third note, it reduces the amount of scatter to the operator. Now, newer pieces of equipment allow you to adjust the collimator directly on the screen. That means you can use the last image hold feature of your fluoroscopy unit to change the collimators, and it gives you a visual indication of where they're placed. That way, if the patient hasn't moved, you're set up and ready to go for your next procedure. So the final point, just to reiterate, the operator should always try to collimate as much as possible using the last image hold images. This prevents non-diagnostic exposures while adjusting the shutters in real time. Positioning the patient correctly in the X-ray field is another way to make sure you're both optimizing the patient dose and getting the best image quality possible. In this first picture, you can see that it says the X-ray tube is too close. That is creating a heavy amount of entrance skin exposure, but also by the time it gets the image receptor, you have a huge spread, so it's not necessarily irradiating the part of the body that you want imaged. In the second picture, the image intensifier is too far from the body, so you may get distortion in your image. In the final picture, we have our perfect setup for optimal position. The X-ray tube is far from the patient, and the image receptor is near the patient. Radiologists should consult with the radiation safety officer or medical physicist at their institution to review the dose savings features of the equipment within your department. The medical physicist performs image quality checks to include spatial resolution, high and low contrast. They also do X-ray tube compliance in accordance with 21 CFR 1020 and BUMED instructions. They also test shielding adequacy verification and entrance skin exposure. But keep note that if there are any major repairs that need to occur, your department will need to coordinate with Biomed to ensure that a proper field engineer comes and conducts maintenance in accordance with manufacturer's procedures. We finished talking about radiation exposure to our patients. So let's go on and talk about radiation exposure to our staff and how we can minimize and optimize our radiation exposure through occupational radiation protection.
Occupational radiation protection provides the appropriate level of protection for the task at hand and maximizes the benefits attained through the use of radiation, the end goal being prevent harmful deterministic effects like erythema and reducing and minimizing the probability of occurrence of stochastic effects like cancer.
During imaging, X-rays can interact with several things to create scattered radiation. The first being primarily inside the tube head. When it interacts with the X-ray target, X-rays travel in all directions, and the tube head itself is designed with shielding to limit the scattered radiation coming from the tube head. Next would be interaction with the air that's in between the tube head, the patient, and the detector, because there are particles in air, and when the X-rays interact, they can scatter in other directions away from the patient. Next would be backscatter from the table or detector after it has traveled through the patient. And finally, the interaction with the patient itself. It's important to note that because the mass and density of the human body and the lack of shielding around the patient is the origin of the majority of scattered radiation during fluoroscopy. Now, the three factors that affect scattered radiation are the length of time of the irradiation, the X-ray field size, which is controlled by collimation, and the size and density of the imaged anatomy.
The equation on the screen is used to calculate the energy of scattered photons as a result of photoelectric effect or Compton scattering. Note that theta, the scattering angle, will vary from 0 to 180 degrees. X-rays interact with tissue primarily through Compton scattering, releasing an orbital electron and deflecting the X-rays in the process. The graph on the screen depicts the distribution of scattered photons as a result of interaction with matter. The highest radiation exposure rates are seen from 60 to 120 degrees from the patient. Take a look at the horizontal isochroma map on the screen from the technical manual of one of our C-arms.
The shape of the isochroma map is actually similar to that we expect from a probability of the scattering angles.
As a rule of thumb, the exposure rate to personnel standing 3 feet or approximately 1 meter from the patient would be about 1/1000th of the patient's entrance skin exposure if no protective measures are used. Take a look at the next excerpt from one of the technical manuals for one of our C-arms. The technical manual shows an isochroma map using a 25 by 25 by 15 centimeter water equivalent phantom, and they expose the water phantom to 110 kilovolts and 200 watts, approximately 1.8 milliamps. The exposure at 1 meter is actually approximately 1 milligray per hour. But to further demonstrate this, I set up a test for 110 kV and 210 watts, that's as close as I could get, with a CTDI Vol phantom used in CT testing, which is a cylinder. The entrance skin exposure that I measured was 1090 milligray per hour, and at 1 meter the exposure rate was 0.632 milligray per hour, which is approximately 1/1000th of the patient's entrance skin exposure.
With scattered radiation, let's do a quick discussion on C-arm positioning. You'll see two pictures, one with the X-ray tube above the patient and one with the X-ray tube below the patient. The X-ray tube above the patient is incorrect. The operator is not shielded by the image intensifier. Scattered radiation from the air particles in the air are directed at the operator, and the operator is closer to the X-ray tube housing. The X-ray tube below the patient is correct. The operator is shielded by the image intensifier. Scattered radiation from the air particles are directed downward, and the operator is further from the X-ray tube. So if your procedure permits, make sure your X-ray tube is always positioned below the table when using a C-arm. When the anatomy being imaged is centerline in the body, make sure that you as the operator are as far away as possible. Now when the anatomy is non-centerline, position the anatomy as far away from the operator as possible. In this picture, it would be best to orient the patient 180 degrees so that the anatomy is on the other side and less scatter would be coming towards the technologist or radiologist.
Operators should do a few things to become familiar with the equipment. Obtain guidance from the medical physicist that's in charge of surveying the equipment. Participate in qualifications at the departmental level to document that they're familiar with the equipment. Participate in routine applications training that are available through purchase from the manufacturer that can be facilitated by your department head. And research and review of technical manuals. Thinking about technical manuals, you can enter the technical manual and look for the isochroma maps that we previously mentioned, but also they have maximum local dose rates to the operators in various positions. So in this example, They used a load per hour of 10,800 mass and used 3 different safety zones of A, B, and C. They also documented that when the unit is in the vertical position and the horizontal position, there are various exposure zones so that the operators know what to expect in terms of the air kerma rate per hour. Radiation exposure is unique in that it is the only occupational hazard where just operating barely below established limits is not good enough. Companies can still sustain legal liability even if limits aren't exceeded. All facilities and organizations are required to employ good practices and implement radiation safety programs to ensure that the as low as reasonably achievable, or ALARA concept, is obtained. Those 3 main principles are time, distance, and shielding. With time, dose is equal to the exposure rate times time. So using last image hold and pulse fluoroscopy features are technical advantages in reducing the total time X-rays are produced. With distance, increasing the distance from an X-ray source has an exponential reduction in the dose received, so maximizing the distance has a much greater effect on reducing your dose. And with shielding, by using 5mm equivalent of lead aprons, operators can reduce transmission of X-rays by 95%, meaning only 5% of the X-rays transmit through the lead and reach the body for interaction. Transmission of X-rays through a lead apron depends on several factors: the energy of the X-ray radiation, the material constituting the barrier, and the thickness of the material. Additionally, when performing interventional fluoroscopy, always wear leaded eyeglasses, but consult your radiation safety officer to determine if lead glasses should be worn during diagnostic fluoroscopy. It's one last point that we need to mention that lead apron use is highly scrutinized by the Joint Commission accreditation. I've gone through 2 accreditations myself, and both inspections or accreditations, they've asked various departments in my hospital to see lead apron inspection logs and have asked many staff members how they're checked, how they're used, and when they should be employed throughout various procedures. The guiding regulations for the U.S. Navy are the NAVMED P5055, the Radiation Protection Manual, and DHA Administrative Instruction 87 for radiation safety programs. Basically, as a radiologist, medical physicist, or radiologic technologist, working with radiation is your primary job, so TLD wear is always required. Now please note, when you're performing fluoroscopy, if only one TLD is provided by your department, your TLD should be worn on the outside of your protective apron on the collar. At many institutions, ALARA policies include 2 sets of criteria for evaluation: an upper level used to set the annual or quarterly limit, and a lower level used to set a local standard for assessing values or results against those that are typical and expected. The Bureau of Medicine and Surgery has established the upper guidance for occupational exposure limits to be limited to 50 millisieverts or 5,000 millirem per year, and declared pregnant workers are limited to an exposure of 500 millirem for the entire gestational period of 10 months. In support of our lower limits, the Joint Commission actually requires healthcare facilities to designate a radiation safety officer in writing. He or she will make certain that radiologic services are provided in accordance with law, regulation, and organizational policy. Specifically, the RSO will monitor and verify compliance with established radiation safety practices to include oversight of dosimetry monitoring. At my healthcare facility, I have the following local control levels in place: a quarterly whole body exposure of 25 millirem and an annual whole body exposure of 100 millirem. If any quarterly result comes back greater than 25 millirem, I am immediately notified as the RSO, and a review with the technologist or radiologist is conducted. This is not punitive in nature, but rather a trigger to conduct a review of safe ALARA practices. This concludes the content of today's training. Let's highlight some of the main points that you should take away from this training. To minimize patient dose, the fluoroscope operator should use the least magnification and smallest collimation area that facilitates the diagnostic task at hand. Always wear lead aprons and thyroid collars, and when told to do so, wear leaded glasses. Always wear your dosimeter. Call the radiation safety officer and/or medical physicist if you have questions about your equipment or your radiation dosimeter, and communicate with the technologist to better utilize exposure techniques such as pulse fluoroscopy, correct position, and collimation.
This curriculum was developed by Lieutenant Jeff Caudill, that's me, and a special thanks for the peer review from one of my best radiologists that I've worked with, Commander Jade Janota, and one of my radiation health officer colleagues, Lieutenant Ben Cabin. Thanks, guys.